So hello everyone, and thanks very much for joining us this afternoon. So when he was out and about promoting Dr. Strange a few years ago, Benedict Cumberbatch said this about people who work in the NHS. Anyone who works in the NHS has superpowers. It's a miracle, it's magic. And absolutely the true magic of the NHS is the people. And that's wrapped up in the knowledge and skills that the people bring to the work and their appetite to continue to learn through every stage of our careers and the way we work in teams and across professions, and not least our passion to improve the quality of care in the NHS. So in this session, we're going to introduce a couple of really tried and tested quality improvement tools. They're relevant whatever your choice of career. And remember, there are 350 careers in the NHS. We're going to share an example of how to use these in practice, and we're going to try and whet your appetite to find out a bit more. But first, we're going to tell you a little bit about ourselves and how we have worked together. So over to you, Farzana.
Hello, thank you, Sue, and thank you everybody for joining us. I'm delighted to be here. So I'm Farzana Hussain and I'm a GP, and I work in Newham in the East End of London, and I run a practice. I'm a GP partner looking after 5,000 patients. And since I learnt about quality improvement tools just about 3.5 years ago, it has improved care for my patients hugely, and I'm going to be able to share some of that with you and hope to whet your appetite for quality improvement, because you don't have to be a doctor to know about quality improvement. In fact, some of the best people in quality improvement are not, and that's how I met Sue 3.5 years ago on an NHS England funded program called Time for Care, and she actually taught me on the GP Improvement Leaders program, and we have been in touch and remained friends ever since. So thank you, Sue.
Thanks, Farzana. And I'm the national lead for NHS Library and Knowledge Services. I work for Health Education England. For those of you who've never spotted it, there are 185 library and knowledge services in hospitals across England. And I actually trained as an information scientist. Did a bit of work before I came into the NHS, and I started out in what would now be called public health. The golden thread through my career has been about wanting to make sure that the decisions we make in the NHS day by day are based on the best information that we can have, that we can use the best information as staff and as patients. And that has led me to take a whole series of career choices through the way. And I worked in general practice for 20 years. I advanced through various roles in knowledge management and so on. I became a director of a clinical commissioning group. But the loves in my life have been getting evidence into practice and improving the quality of care. And I'm really fortunate that I've been able to bring those two things together through my career. Because it turns out that getting evidence into practice is really quite tricky and much more complex than I could ever have dreamed of. I wasn't naive. I didn't think people made decisions only on the best information. I knew they had to take a whole ton of other things into account. But as I grew more interested in the human factors of change, the day came when I got the chance to learn some quality improvement techniques. And for me, it was like the missing piece in a jigsaw. I just wish somebody had taught me about them before. And that's one of the reasons that I'm here this Saturday afternoon. It was like discovering that missing piece. So I became a member of the primary care improvement faculty, worked with a lot of groups, led a lot of general practice improvement leads, workshops and cohorts, introducing people to techniques, and that's, as you've heard, how I came to work with Farzana. So now you know a bit about us. Farzana, I'd love you to share a story about using quality improvement tools in your practice over the last 3 months. And as Farzana shares her story, the immediate relevance of this work will become blindingly apparent.
So Sue, thank you. So over the last 3.5 years, we've done various projects, but the one that I'm going to talk about is the one that we'll talk you through today. And the reason I think it's so important is because this was as a direct result of COVID. We're obviously in the middle of a pandemic. It's an infectious disease that we have no cure for. We have no vaccine for at the moment. And what I was finding in my practice, if you're in a general practice, for those of us who aren't quite sure, we are one of our duties is to make sure that our children, our babies and our young children are immunized against other infectious diseases. So there's a whole array of them, from measles to mumps to rubella to diphtheria. And we were finding that our babies were not being brought in for their injections because, of course, mummies and daddies and carers were concerned about exposing them to COVID. Now, we used to do 12 injections a week on our babies, and we found that went right down to 3. We also know, don't we, Sue, that actually to try and get protection against any infectious disease, whether that's flu, whether that's mumps, we need something called herd immunity. So Sue and I and the 30 of you can have our injections, but actually if the other 70 people out there haven't, then none of us are protected. So it was really important to me to keep not just my patients safe, but to keep community safe and England safe as a whole, to make sure that those injections were still being given. So I thought to myself, how can we ensure that people still come in and bring their babies in to protect them and have their injections while minimizing the risk to COVID? Because we know that it's that face-to-face contact that, you know, noses and sneezes and everything we know why we wear face masks, that's important. So that was the problem. And our objective was to keep the face-to-face contact for our practice nurse who administers the injection to a minimum, and obviously wanting to keep the face-to-face contact for our patients and their carers to a minimum. So what was our solution? How about a drive-through childhood immunization clinics? You've heard of the McDonald's drive-through. What about a McImmunizations drive-through? So thank you. So if we go on to our next slide, be able to just see. So Sue, I'm going to just be very quick about this and then get you to talk about things. So I'm a busy GP. Many of you are busy students. Many of you are busy workers. I don't have a lot of time to worry about complicated things. And I have a little brain, so I don't remember lots. So I have only really remembered about 3 tools from QI, and it has had such a major impact. This is one of them. It's called a process map. It's a map. It's really visual. It's got really pretty colors in it, and it's really easy to understand. And we used one of these to design our drive-through clinic, and we did it in 15 minutes. Now, we've done a few of these in our team, which is why we were able to do it a bit more quickly. But I would say, Sue, I know you're going to talk us through it. The 2 things that are the key ingredients of a successful process map, and therefore a successful project that you're delivering, is to have the right people in the room and to start slowly. So I have my ideas about what I want, sitting there as a doctor thinking I know everything. But actually, my reception team need to be in my room, and my nurse needs to be in my room. And it's really, and hopefully patients need to be in the room. So getting the right people in, and as many people in, is important. And also sometimes the simplicity of these tools is deceptive, because they say, oh, well, I know that already. You know, well, I know how to brush my hair, actually. But could I talk you through how I brush my hair in the morning? It's almost automatic. And you might say, so, well, why are you holding the brush in your right hand, not your left hand? Because I see that you do more with your left hand. And those are the sort of things that are useful. So is it all right if I get you to just talk us through a little bit about the theory of the process?
Yes, just some practical tips, really, and grounding it. It's often a really first step in quality improvement, because it's a cold, hard look and it's a reality check. It's very easy, any process that we do, to just see our slice of it. We can see the piece we think, and we think we can describe this. And certainly when I've used this tool in my work, in practice, in primary care, you know, people have often said, well, we know about this. It's perfectly clear. And so that's great. If it's perfectly clear, you just draw it up. Everybody else will come and look and agree, and we'll all get the next cup of tea and find a biscuit, you know. So that issue of having everybody in the room is really key, because the process looks and is experienced differently by different people. So it helps you understand what you're describing here. You're not redesigning on the hoof. What you're describing here is just current process, warts and all, from beginning to end. And it helps you look at the problems, it helps you look at the bottlenecks, it helps you look at dependencies. want to start to show just how long some of these stages are taking. And, you know, people will learn, so we get that done within 2 days. But when it goes really badly wrong, it might take 14 days, you know, or could we just do this in 35 minutes? Let's find out. So it shows where it's unreliable. It shows where different members of the team are having quite different experiences. But as Farzana has emphasised, for it to be a truthful map of the process currently, you really need the right people in the room. You need to give voice to everyone who's involved and engaged with that process. That gives you a shared understanding, but also clearly a range of other people come up with great ideas that you might never have thought of on your own. And that is one of the pieces of the magic, is bringing teams together. So it gives you joint ownership, and when you come up with some ideas, it will help you prioritize. The other thing with this is you'll start to find what you can measure. We all have assumptions about the volume of activity, about which days things happen, those kinds of things. Once you start to really get a sense of that, you can measure it. And remember, if you can't measure it, you can't manage it. So it's good fun to use. And, you know, this is really practical. As Farzana has said, the process map she's going to show you in just a moment, they did in 15 minutes in her team with the right people in the road. So what you're mapping is your process steps, your decision points and questions, anything that's a pinch point, a problem, something you're worried about, something that somebody in that group feels a discomfort about that you might never have noticed. You're also obviously looking to generate ideas about how to sort it. Where are you going to take your actions? You're not doing that on this map, or you're not drawing an imaginary map where you have magically solved things with one single idea, very rarely a single bullet. So really gets people talking and thinking about solutions. You can put them up on the wall, along a corridor, even in a reception area, staff room, and start to map your timeline, because that will show you where your disappointments sit. Do you want to bring this all to life now, Farzana? And I'll click on to the next real process map that you drew.
Sure, thank you, Sue. So this is a real life process map that we made for our drive-through clinic. And you can see the yellow across there is the actual process, the pink were the problems. So if I look at the pink on the left there, it was a problem that was brought up by my reception manager, Emma. So there I was, all set to go. Yeah, we need a drive-through clinic. It's going to be great. We're going to immunize the babies in the car. And then Emma said, what about all the people where I work in who don't have cars? So I would never have thought of that. So that's really useful, because she's a reception manager. She's more used to seeing people arrive, and she knows who's got cars and who hasn't. I'm sitting in my consulting room. So this demonstrates the importance of having as many views as possible. So after we recognize that problem in pink, well, in blue, what's the solution? We thought, well, why don't we class a pushchair and a buggy as a vehicle as well? Because many of our babies have buggies. So that's just one example of working through the process and having that planned beforehand. And as you can see, it's, you know, not a massive map, and it's really good fun to do. And, you know, this is what a real life one looks like. It also, I thought, Sue, and I know we've spoken about this before, helps equal voices in the room, because sometimes probably my bossy personality, but, you know, when Farzana's there as the GP partner, it's quite hard for a reception apprentice to say, hang on a minute, I think you might be wrong. And with a process map, you don't need to worry about who's wrong, who's right, who's more senior, who's more junior. You know, I've had, when we've taught medical students, I've had medical students say, and what do you think of this? And it's fantastic, because sometimes it's that, you know, those people, you guys listening, probably have the most freshest ideas, and the process map makes it really equal and people all have a voice. Yeah, thanks.
It's really key. And I'm just going to go back if I can. So it is a very pretty process. I described the points that you're measuring. Really doesn't matter what colors you use, guys, just make sure that you're consistent. And it's helpful if you show the post-it notes the other way around, you know, if you get this this effect when you're trying to show the decision points, because they're key points. You can use it for questions as well. So it's a really simple tool, and you can use it for anything. You don't have to wait till you're a senior partner like Farzana. You don't have to wait to be the national lead for whatever it is. Actually, this is something you can use in your everyday life and your own work and study now. So we're going to go on from having talked about this one quality improvement tool to talk about another, Farzana, which is the model for improvement. Yeah, shall I go on to that?
Please, please.
So this is the second tool that we wanted to show you today. And again, it's this is really key. This is whatever else you take away and think about in terms of quality improvement. This is the one thing I'd like you to hold on to as a sort of stick of rock through your quality improvement work. Now, what I find, and if there are people who are trainees or trainers or further down their career listening in, what everybody talks to me about is the PDSA. Oh yes, PDSA, they say. We talk about this model, which is very tried and tested. I mean, it's 25 years old now, being used in many, many different settings. The thing about the model is to start with this bit. 3 fundamental questions. What are we trying to do? What are we trying to accomplish? And this structured approach means we get the benefit of really, really clarifying our aims. We can be really clear about what we want to do and start to describe that in smart ways. So things that are really specific and measurable, that they're time related, they'll relate to a particular population. Once you can start to tell people what you want to do, they can get on board and helping you, and you can start to really define what it is you as a group want to achieve. If you can't describe what you want to do, unbelievably difficult to get people on board and impossible to know whether you've done it. Which leads to the second fundamental question, which is how will we know that change is an improvement? Now, I've been involved in many, many change projects during my career, and quite often you find yourself saying to somebody, what was this for? What were we trying to do? And then you get to this piece where if you do pieces of work where people think it's been really, really successful, but if you actually measure against what you were trying to achieve, you've only got part of the way. And in fact, that's with major changes, that's the norm. And using tools and techniques like this help us really expand our success rate and become much more successful. So when we're thinking about how will we know it's an improvement, that's because we need to sit back and say, well, how will we measure this? What will we establish as the measure of change? And it might be a qualitative measure. How do people feel about it? But it is likely to be able to be something that you can define and specific. You're reducing something from so many hours to so many minutes, from so many days to so many minutes, with length of stay in a hospital bed, for example. You might be measuring patient satisfaction improving from this level to this level, and you might be improving a sense of staff well-being from here to here. So you want real measures in there. And then you come back to that piece where we talked before about the process map and about coming up with ideas, and often laying out the process will allow you to say, you know, we could do that differently. We could think about that differently. So what changes can we make that will result in an improvement? And I'll repeat what I've said earlier. There are no magic bullets. And as you measure it, you can see the difference that different changes are making and together contributing if you test them simply one after the other in ways that you can follow that through. So 3 fundamental questions, answer those first, and then think about planning to implement that, doing what you want to do, reflecting and seeing what the data tells you about what you've achieved, and acting. That again is not a 2-year program plan, and Farzana will talk about that again. But the thing that I would particularly say, those of us who have worked in general practice a lot, you know, we're really roll your sleeves up people. Roll your sleeves up, got a great idea, let's do it. Let's have it all sorted by lunchtime. Yeah, actually very similar to working in, you know, in commercial enterprises. Very fast, let's see what we can do. that is wonderful, provided you have answered your 3 questions and you have planned. And remember that a goal without a plan is just a wish. It's just a wish. You've got to have a route through to deliver. So maybe we're not natural reflectors, but the area here is to put more time into the planning. Do make the change you want to make, get that done, use your measures, reflect and study, see the data, look at the data, make sense, and then determine what action you might take next. So Farzana, how is that for real? Come on, people are not going to believe that that doesn't take forever and ever.
It's amazing. And again, back to Benedict, it is a bit of magic. No, actually, it's these tools. So what were my 3 questions, the answers there? What was my aim? We wanted to reduce the face-to-face contact time when my nurse was giving the injection from 10 minutes to 2 minutes. And we wanted to do that right away from week 1 of COVID, because we wanted to reduce it. So very clear, what are we trying to accomplish there, Sue? Yeah?
Yeah.
Okay, thank you. Next. And so here's our plan, do, study, act cycle. So some of the planning came, so it was things like, how are we to reduce this time? So we chopped up our consultation into 3 parts. So prior to COVID, mummy and daddy and or carer would bring baby into nurse's consulting room, 10 minutes face to face. The first part of the consultation would be my nurse explaining all about the vaccines, all about why we need to give them, all about the side effects, making sure baby wasn't feverish or anything. Then the middle part of the consultation was doing the vaccinations. And then the end part was writing up the records on our computer and also transferring that data onto a child health record that every child has. We call it the Red Book. So part of the planning was, how do we make sure that we cut up that consultation into 3 bits, and actually our parents would drive up or come in a buggy and stand in the front garden, ring our reception team to say, I'm here, so that there's no COVID transmission risk between even reception and the parent. So that's 1 less face-to-face contact. Then my nurse would call my mummies and daddies to explain the vaccines on the telephone, so that again, there's no COVID risk. Comes out for the middle part of the consultation, giving the vaccinations, and then goes back inside without mummy and daddy to write up the records and text it. So that was planned. We started that 3-hour clinic. As we were doing, of course, as you do stuff, you roll your sleeves up, you think, oh, this might not be working out. It soon transpired that actually my nurse needed an assistant, because she can't carry the sharps box, the anaphylaxis kit, all the injections and everything. She'd need like 3 pairs of hands. So we thought, so that was a bit of study and a bit of action. So the following week, she came out with an assistant. We did it the following week. And then we had started off, because it was a new process, we thought we'll get the healthcare assistant to actually write the records to save some time. By week 2, my nurse said, you know what? I can write the records. I feel more confident writing the records. I've done the injections. It takes me a minute. So that was a second plan, do, study, act cycle. So really, Sue, what I would say is, although the tools are maybe new to some of us, you can do these multiple changes really quickly. So how did we reduce this exposure to risk? So that was our process in the planning. Our admin lead was ringing, the patients and carers came in. The first part of the consultation is on the telephone. Then nurse comes out for 2 minutes just to immunize the child, and then writes up without the patients there, and we'll text that information. And there we are. Thank you, Sue. Next slide. And these are just some pictures of our wheels. So you can see on the left, on a rainy day, we're lucky that we have a little covered heated porch outside our practice. So there are nurses giving a baby injection there for the wheels that are the buggy. And then there's one in the car. And we are now going to use this for our flu vaccination campaign later this year, Sue. That's what we're going to do, the drive-through model. Thank you. Next slide. And here is, so Sue, I've kind of just described how we use some multiple plan, do, study, act cycles very quickly. Would you be able to just talk us through?
Yeah, I think there's just a couple of points on here, really. What you're trying to do is test one thing at a time, very small tests of change. Because your idea about how you're going to do this, the whole idea of a drive-through clinic, you know, is a hunch at the beginning. You know, it's a hypothesis that this is going to work. And then you do your first test, and then you realize that you've pushed chairs, you've got people coming in on foot with families and so on. So you're easing your way through really testing it out, easing out the wrinkles. And as you're doing it, you're becoming more and more confident in the solution. And the staff are becoming more and more confident. So you started with 1 3-hour clinic, but you could, with other changes, start with 1 patient or 1 service user. You could start with 1 doctor in 1 surgery and then build that up, 5 patients, all the doctors in the surgery, and start taking that through. And then you take each one of those through that plan, do, study, act cycle, remembering that all the time you're still answering those 3 fundamental questions. Can I test and refine some ideas? Can I implement some new procedures and systems? And building the confidence to sustain that, you know, is one of the is a really powerful piece around this particular tool, because it's not just a change you make on a Monday and there's chaos by Wednesday. You build it up really small through cycles of change and build the confidence so that you have got changes that result in improvement. So, Farzana, I know how pleased you and the staff are. Do you want to tell me what families thought about all this?
Yes, definitely, Sue. So that was obviously a concern, because it sounds a bit odd, doesn't it? You're used to coming into your general practice and we're saying to you, do you know what? We're going to come out into the front garden for you. There's windy days, you know. This is a mum who's given me permission to share her name, and that's not her baby. That's just a cute baby. Mum was beaming when I was in my nurse was doing the clinic, and I was, you know, watching, and she was beaming from ear to ear, and I was just thinking, what is she so happy about? You know, it's not a nice Tuesday morning. And I said, may I just ask you why you're beaming? And she said, well, this is what she said. I'm so happy you kept my baby safe. She said, I know you guys are in your protective personal equipment, but nobody knows what people are carrying inside a waiting room. I didn't want to go in, and I wouldn't have brought my baby if I had to sit in the waiting room. I feel my baby was protected, and now I'm going to bring my baby for the 4-month injections. And that absolutely capped it for me, because this would have been, her baby would have been a baby that would have been left not immunized against 6 diseases, and it was amazing. I have to say, our patients have been really with us on this, and if I could go back, Sue, because this was done in a sort of rush COVID time, I wish I had had some parents in the process map phase. You know, don't worry, guys, about you know, inviting, but in fact I would encourage inviting, because it gives you another point of view, and ultimately they're the end user, aren't they?
Remind me again, Farzana, what was the time difference that you were trying to achieve here, and what did you achieve in terms of exposure?
So it was from 10 minutes to 2 minutes, so it gone down to a fifth.
And how quickly did you achieve that using these techniques?
We managed to do that from the first week. It was that impactful. It was from day one. The coverage rates, our second aim wasn't reached immediately. So we have got a second aim. Again, as Sue says, remember, always go back to what it is you're trying to achieve. Something Sue always says to me that would be lovely to share is that anyone can make a change, so that I can decide, you know what, I really need to do some exercise. I'm going to go on that rower of mine that I bought 3 years ago and that I hang my washing on. And I can do that for 1 day. But sustaining a change is really hard. And quality improvement has given me and my team the tools to sustain that change. Because now we're on week 12, they don't need me in the building. They don't need the doctor in the building. They're just doing it, and they're doing those plan, do, study, act cycles. So our second aim, Sue, was to increase our immunisation coverage rates from the 25% it had fallen to at least 75%. I'm pleased to say by week 6 we were there. We're at about 80% now. So we managed to immunise about 10 out of 12. We used to do 12 a week, do about 10 now. So we're not still at pre-COVID rates, but definitely getting there. And people seem to be very bought into the drive-through idea. You know, people are telling their friends, you know, oh, it's fine, it's safe, bring your baby. So as word gets around in the community, you know, we're hoping that will increase.
So I know that for you, Farzana, as for me, learning these quality improvement tools and techniques was revelatory, really. So to go back to where I started, it is really a bit of magic that we can all wrap into our skill sets. And we don't need to wait to do that, as I said earlier. So if we have whetted your appetite, I really encourage you to come and look at the Improvement Hub that sits within NHS Improvement. There's a shed load of different tools and techniques, and we've chosen 2 that we think actually are accessible to anyone. That from this slide set, you could give these a go in whatever stage you are in your aspiration towards your career or in your career. So we encourage you to have a go at that. And clearly, because given my own background, the skills that I look to bring into the team, don't forget that you've got library knowledge specialists there. And yes, they are all working in the health service. They're all available digitally, providing a virtual service. Public libraries are, of course, always there, and you'll have college and school and university libraries, some of you too. So Farzana, I think that we will bring it to you to wave a little bit of magic at the end with any questions, okay?
Definitely, Sue. And I think I would say to, you know, anybody listening, just to reiterate, you know, I waited till I was, you know, 44 years old to get these skills. And it was only when I got to this course that I thought, oh, now I understand why half my ideas never bear any fruit. It's not that I'm lazy. It's not that I'm stupid. It's just that I don't have the tools to go with it. You don't have to be a doctor. I wish I had learned this at medical school. I wish I had learnt it earlier. You know, it's really, really good. I mean, I've used it with my teenage son to think about when we used to fight about his Sunday night homework, you know, and I used to say, do this, and telling a teenager what to do. Probably you guys may know when your mum and dad told you what to do, you just didn't do it. And sort of using some of those skills, he was able work out and process and decide when he wanted to do stuff. So gave him the ownership to do it. We looked at it and he was successful. So you can use it for anything really. So thank you very much. James, I might actually look to you, see if there are any other questions coming in. I don't see much in the chat box. Ramissa, we certainly will be sharing the slide. So I'm sorry we didn't go back to that slide, but we will be sharing the slide. James, could you help?
I haven't had any questions come through, sadly. I mean, there's a lot to talk about in there. I love the bit about dreams without goals are just dreams and stuff like that. I think that's fantastic advice to just not just general practice, general life. Yeah, no, it's fantastic. We still got
George has asked, how does this tie in with health management? Is that for you, Sue? Tie in with health management? Can you answer that?
Well, I took a career that led me through to senior management, and you know, I've always wanted to make sure that quality improvement is wrapped into the skill set of the teams I work with. If you're in large hospitals, you may well have service improvement teams who absorb these skills and come and work. But this isn't just about clinical practice. You know, huge amounts of what we do, the 350 disciplines, we probably talk in the system on the news about 4 or 5, a little bit more talk about scientists this year, but there's another 300 people keeping this show on the road. And for each of us, process is part of that. It's just a routine part of how we work. And engaging with others and understanding, you know, one of the risks for managers is that they either get reports back which don't reveal which bit of the process is a pinch point, what's concerning people, or they too may not have the skills to bring to it. So I came across these tools and techniques when I was working on a large scale quality improvement change program, But what we were trying to do was, you know, our goals were to engage clinicians and make sure that primary care was clinically led. We were trying to get evidence into practice, and we were trying to push more public and patient engagement. And each three of those strands, all of which were managerially led, actually, needed, needed quality improvement schools and all sorts of process behind it. So just as applicable in your management life. And certainly for my own team, we're introducing these, and actually we're introducing them across the 1,200 libraries in the service, because we want them to improve their services in order to release more time to do the thing that only they can do. And I'd advocate that approach to teamwork. You'll want to bring our own skill set in where it's unique, and get rid of the noise of unnecessary process. And if that helps.
This is a good question from Anthony, isn't it? How can these skills be applicable to medical school applications and interviews? So that's a really good question, Anthony. I think they can't you, Sue? Particularly with the again, if we look at those three questions, what we're trying to achieve, how will we know? Certainly the plan, do, study, act cycle, I think can be really, really useful for this. So what are you first of all, Anthony, have you chosen some medical schools? Do you know why you've chosen those ones? Thinking about your planning, what sort of things might you want to anticipate that they might ask you? What sort of planning do you want to do? Then maybe you go to an interview, you're doing that bit, and maybe there were some surprises in that interview, some good surprises, some things that you might want to improve on. That's then your study bit, and then you're acting differently. So I remember, I'm 47 now, Anthony, so this was many moons ago, but I went to a medical school interview, and they said to me, I notice your dad's a doctor. And I got really defensive, and I said, yeah, but that's got nothing to do with me. That hasn't influenced my decision, because I really wanted to be known for my own right. And then I heard myself say it, and I thought, gosh, I got so prickly about that, as they were just asking a question. And so I went back from that and reflected on that. But that, that's the doing. And then I thought, maybe Farzana, next time, don't be so prickly if someone asks you that question. And then, the next time I acted, I was like, yes, that's correct. So I know a little bit more about the life of a doctor, and I was able to frame it more positively rather than, yes, but that's not why I'm applying for medicine. So that's just an example of how you can use the plan, do, study, act cycle. Would you have anything to add there,
I think showing an awareness that, people join the health service based on values. We all want care to be the best it can be. And if that's the case, coming to, just reflecting that you have an interest in quality improvement skills, that you know that everything isn't perfect, that we want it to be as good as that we can be, and that to achieve that, there is behind this a body of work called improvement science. I'd encourage you to go and look at the improvement hub that I've shown you here. I'd encourage you to look at the Institute for Healthcare Improvement in the States and look at some of their white papers and more theoretical pieces on this, because there is a body of improvement science. And if we want, the thing I said at the beginning is, what I realized was that if you were going to make change, you need to understand about the human factors of change, and you need to understand the tools and techniques by which you can achieve it. And they are not process you achieve. And it's lovely to be sat in my living room study on a Saturday afternoon, but actually you've got to have a lot of other people on your team screen if you're going to make these kinds of changes. You need to engage with the whole of your staff, the people you're physically working with, the people you're engaging with, and other partners, if you're going to make a change that sticks. And so underpinning these quality improvement tools, you will find there is an enormous about how do you engage with people, how do you establish common purpose with people, how do you all get on the same page as to even what's happening now, which is where our process map came in, and how do you look at a structured approach to make sure that you're really answering important questions and using a reflective but fast and quick active approach. to managing change. So I think just a sentence or two that says that you're interested in quality improvement techniques and improvement science, and you really want to get to using some of that as you go forward, would stand anyone in good stead.
Brilliant. Okay. That is our time up for today. Thank you both for coming along and doing this presentation. It's been very eye-opening, and hopefully students can apply it to their interviews and anything in life. I mean, it's very much it's not just a story for general practice or healthcare. It's very much been about the wider use in life. The Plan, Do, Study Act. I'm definitely going to try and implement that into my medical studies in the future. And yeah, I think that's it. Thank you both.
Thank you.
Keep in touch, guys. Take care.